Good morning, everyone. This is Rob Spector, and welcome to the September 9th Plan Management Advisory Work Group. We'll start out, I'll ask Elena to take a look at the attendees and announce committee members and board members that are participating.
Thank you, Rob. The members that we have online is David Brabander, Douglas Brosnan, Amy Frist, Hector Hernandez Delgado, Rick Crum, April Martin, John Newman, Rob Spector. We also have Jerry Fleming and Doug McKeever joining us.
Great, thank you, Elena. And I'm sure everyone's used to this now, but just a reminder to use the raise your hand function or insert questions. And then Elena will help facilitate the dialogue throughout today's discussion. Looks like we'll be able to get through in about an hour or so an update around on the next page, please, where we're thinking for the 2023 plan designs, an update on the 23 through 25 contract revision process, and then a discussion around the attachment 7 and QTI updates. And with that, I will hand it over to James to get us started on the first topic.
Yeah, thanks, Rob. Wait for Elena to get to the first slide here. Okay, so for those of you who have been with us for a while, you know we've been looking at value-based insurance designs, and we're looking at putting forward a proposal when COVID hit, and we delayed it while we focused on obvious other issues we needed to deal with. But it's time to come back to this subject, and I know we have interest from carriers about it, and I'll go over to the next page to show some interest in others as well. And what we're looking at this time is a focus on diabetes. The last time we were looking at it, it was going to be more expansive and cover more conditions, but given the short amount of time we have to look at this before we go forward with the 2023 standard benefit designs we need to develop, as well as some of the things we've learned since then, we thought it'd be best to start with diabetes, and then maybe we can expand the program further in the future. Of course, the specifics of this design will be developed with input from all of our stakeholders. We have some concepts we want to put before you, really kind of a rough sketch right now, and welcome your feedback. And you don't have to provide feedback today. You can think about it, talk with your colleagues, and come back to us later on this topic, because we will be delving into this in more depth in the future. So let's go to the next slide. Okay. So this is just some context of what's been happening out in the industry on the topic of diabetes medications. There are bills that would prohibit having diabetic or diabetes medications subject to the deductible, certain ones requiring lower copays, things like that. In addition to this, there was an IRS ruling that allowed certain value-based insurance designs to be covered prior to the deductible, which is kind of new. This is for the health savings account linked health plans, and this is kind of new. Traditionally, the only service that you could cover prior to the deductible for a health savings account linked plan was preventive care, and now they're expanding its scope some. And additionally, we have seen that Massachusetts Health Exchange is requiring health plan issues to offer at least one of each class of insulins in vial and pen injector formulations at the tier 1 copay amount for each metal tier. Additionally, we're looking at metrics around diabetes, in particular, having HbA1c levels below 8% as a quality metric for our quality transformation initiative. So diabetes is foremost on our mind, not just because of what's happening in the industry at large, but also looking at where we are going to be focusing our metrics and our health plans efforts in the future. So let's go to the next slide. And this is really what we're thinking about, and we welcome your feedback again. Provide it today if you can. If you need to talk to your colleagues or think about it for a while and get back to us later, that's great as well. One concept we're looking at is requiring at least one of each class of insulin in vial and pen injector formula at tier 1, alternately at no cost share. This is something we saw in Massachusetts. We're looking at this. Another idea is requiring at least one glucometer and test strip at tier 1, or alternately at no cost share. and requiring HbA1c testing at no cost share. This is not to say you can't mix and match these, but these are the concepts we're thinking of right now. The next one is minimizing the cost share for metformin, and I'm probably going to mess up this pronunciation. It's a sulfonylureas. I don't know. Dr. Chen can correct me if I got that wrong. And again, at either tier 1 or no cost share. And again, we're not recommending changes in treatment guidelines. This is just a member cost share we're looking at. So with that, I think we should open up this topic for discussion. See if people have any comments they want to make.
Thank you, Jane. Hello, Beth.
Hi, Beth Capel with Health Access. The advocates have been chatting among themselves about these ideas, and we have somewhat mixed feelings about them. We're obviously helping people manage chronic conditions is a good thing, and we're for lower cost sharing. I think everybody knows that. But we also are mindful, after all these years on benefit design, of how things ripple through. And we also, VBID itself originates with large employers as they dump more cost sharing on workers. And so we're not very thrilled about the reason for the underlying concept. And I think that's pardon my home phone is ringing, part of what makes us a little hesitant in this area. We will have specific questions about the proposal, including how much it impacts the NEAV calculation and also the underlying cost of these various treatments and how many, requiring at least one of each class of insulin. I don't know if there are, I don't know in a clinical sense if the drugs in the class are interchangeable for most people or all people, or, so we'll have questions like that as we think about this. And I will say finally that I think from Health Access's perspective, we are mindful that almost over half of your enrollment is in bronze or the standard silver 73, which is really high cost sharing. And until we can get state or federal subsidies to reduce cost sharing for those folks, that seems like that's an important part of the equation for us as well. It's, whether it's bronze or standard silver, we're still asking a lot of cost sharing out of people making not very much money. So thank you. I think those were some of the key points we wanted to make.
Thanks. We're actually looking at a lot of those things, AV impacts and things like that just weren't ready. And so we wanted to bring this concept before people to get their initial thoughts, but also any of the clinicians, if they want to provide feedback on what they think of this approach, it would be appreciated as well.
Thank you, Beth. We have Jen.
This is Jen Flory with Western Center on Law and Poverty. Completely agree with what Beth was putting forward. Particularly the name VBID, because of where it comes from and what its history is. We might want to get away from that if it's really going to be more limited like this, where this seems to be looking more specifically at making things affordable and not really the same kind of steering that we see in VBID, particularly steering or shifting of costs onto patients. And then just, curious, just as Beth is, about how this actually works with each class of insulin. But I do, want to commend, some of the things like putting the glucometer in there, and want to consider both whether there's other equipment that people use, not just for diabetes, that, we should be thinking of similarly. In just kind of our overall concern about VBID is, are we prioritizing some conditions over others? And so we just want to make sure we understand the prevalence of this in the community. And if these are simple steps that will actually bring more equity, we are for it. But we also want to think about what this means for people who don't have this condition, but have other costly conditions.
Thank you, Jen. We also have Jerry Fleming. Jerry, you are self-muted.
Oh, sorry, Elena, I didn't have my microphone on. It looks like Dr. Chen might be muted as well, not just Jerry, so I don't know if you can bring her in as well.
And I believe Carrie Sanders had a comment. Can you guys hear me?
Perfect. Thanks so much, Alice.
Great. Oh, sounds like Alice. Do you want to go ahead, Alice?
No, you go, Carrie.
I don't have that much to add. I think, Beth flagged some of our concerns about, how this will play out when we look at, the AV calculator. We certainly are, supportive in concept of making it easier for folks to be able to access, insulin and glucometers and test strips. But I think, we're also just mindful that we, have such a limited ability to make care more accessible to, a broad group of folks. And so, we'll be curious to hear, how this would impact some of the other decisions that we'll have to make. I note, for example, that the cost of insulin has gone up by 46% over a short period of time. So, while it would be great to make it more accessible for everyone, there's also a part of me that's wondering, are we subsidizing? Are we subsidizing the drug companies in taking sort of this approach versus really putting money, into care and getting care, basic care for folks?
I think, Elena, can I jump in, or is Jerry still waiting to speak?
Well, I think maybe I'm unmuted now. Is that right?
Yep, go ahead.
Yeah.
Okay. Thank God. I thought I was in the wasteland. Anyway, I just wanted to sort of put everybody on notice that in general, I've not been a big supporter of VBID designs. And so, but I'm willing to be persuaded over time and that sort of thing. So I think that it will be important to, in terms of when you bring information to the board and such, one, it may be better to have some sort of interim check-in to see sort of where everybody is on the board as well. And a couple other things. One is that I'd like to be, in terms of I know you're going to be having a subcommittee look at this issue. And I'd like to make sure that you keep me in the loop as far as when those meetings are occurring, so that if I'm available, so I can be on them and that sort of thing. My big recommendation at this time is that try to be more specific about what your goals are here, what problem we're trying to solve. Because if we're going to evaluate these things, we really have to understand why we're doing what we're doing here and that sort of thing. And right now it doesn't, you have some options, but it isn't, you've got some options here, but you haven't expressed how you're going to evaluate them. And it's going to be important to understand that. I also share many of the comments. I agree with many comments that have come from the consumer groups here. A lot of this is, and the AV calculator is a very hard taskmaster in terms of what you can do, and being able to look at what the plans currently are doing around these in each of the each of the, gold, silver, and bronze to get an idea of what actually is occurring now with the plans is going to be important as well. So, and I am concerned a little bit about this. It would be a slippery slope here because it around what, if we're going to do this with one chronic disease, or we're going to start trying to do this with all kinds of chronic diseases, and that's going to shift who's given the AV calculator. This is going to shift the cost sharing to other patients and things. So these are all things we need to consider as we go forward.
Yeah. No, those comments are very much appreciated. And I think I would speak for James also that we're bringing early thinking to the group in order to be able to surface, different considerations and concerns. I will say a couple things. I think we probably should just decide to eschew the term VBID, which I think James actually tried to get me to do earlier. It's kind of talk about ACOs. It's like, it's kind of in the mind of the beholder. So I think it's probably not the most useful term as shorthand. I will say that we are definitely building on the work we did before, which many of you were involved in and preceded my joining Covered California, but certainly there was a much more ambitious effort previously that bumped into a lot of the issues you talked about in terms of the AV calculator, raising costs for other groups of consumers. We are very attentive to that, which is why we're trying to start narrowly. I will say, Jerry, your point about like, why diabetes, why not CHF, why not asthma is absolutely true, but we felt like we needed to start somewhere. And I think diabetes actually is a very compelling use case because both, unfortunately, because of the reasons Carrie mentioned, which is, insulin has increased just absurdly over the last few years. And yes, it is not addressing the root cause of the problem. I think there are other initiatives at the state that are trying to do that in terms of generic drug manufacturing and really pushing on biosimilars. But for consumers who have diabetes now, it can be cost prohibitive to treat a condition that really is one of the key conditions in clinical medicine that if you can get control over up front, you really do save pain and suffering and cost down the line, as we all know. So I think we are really trying to be much more precise, narrow in our approach. We're still working with Mike Chernow and Mark Fendrick to do the evaluation to really try to make sure that we are achieving the goals that we want, which is to reduce cost barriers, to improve upfront, not completely preventive, that's DPP, but like early treatment of diabetes. And that's why actually you see it was in talking with our health plan partners that we added this third tier, because people pointed out that if we just do insulin, which we went to because of cost, you may even have an adverse unintended consequence of people skipping to insulin rather than paying the copay or cost share for metformin and sulfonylureas, which is the first line treatment. So, we're doing this in an iterative fashion so that we can actually surface all these issues and, again, sharing very early thinking, but hopeful that, and the last piece being that obviously diabetes is a place where there are a lot of racial and ethnic disparities. And that was another lens that we used to really land on diabetes.
Thank you, Dr. Chen. We also have a few members that wish to comment. David Brabender.
Thanks. This whole conversation just makes me think of the Medicare world, which I also work in, and Medicare Advantage plans often have a subset of chronic illness plans. And the focus, I don't think, is so much on specifically cost as it is on care coordination and the concept of if we can keep chronically ill folks treated properly, that we're bringing costs down in general. And I would guess that there's a whole subset of criteria that Medicare is using to evaluate those plans. And a number of the carriers that you're talking to, I'm sure, have folks in the Medicare Advantage arena that are probably working those items. And I would recommend trying to find those folks and pick their brains.
Thank you. Rick Crum. Rick, you're muted.
Sorry about that, doing the double mute thing. I just really appreciate the opportunity to be discussing this with Cover California and some other discussion areas. But to hear today, I want to also just mention about trying to just not just the member cost share piece, but if we're able to identify ways to, if we do move forward here, also keep the drug costs down, so that that's just not increased over time as well.
Thank you, Rick. And April Martin?
Hi, April Martin with the California Hospital Association. I want to endorse Dr. Chan's and Jen Flory's comments that say this isn't value-based. Removing a cost barrier is not a value-based plan or activity in many ways, and it kind of shortchanges the true value-based activities that go on among medical groups, hospitals, and health plans in consortium together in value-based plans today, where those people work together as a three-legged stool to try and reduce the cost of care for high cost, high risk members, as well as the balance of members assigned and encountered by them. And so those activities are so extensive and so focused that they really represent an entirely high level of focus. And I just don't see that this initiative, with all of its good intent and with the best hopes for its outcome, should be labeled as a value-based activity.
Thank you for that comment. We also have a few hands raised. Anthony Chen.
Yes, hi. I just want to make a quick comment on the hemoglobin A1C testing. If we wish to align ourselves with the CMS and the Medicare Advantage for their quality metrics, they're recommending hemoglobin A1C at least once a year. So I think if it's something that is kind of recommended to be done, I think it would be a great idea to not pass on the cost to the members. Thank you.
Thank you. And Beth Capel?
Thank you. I muted myself. Seems to be the pattern this morning. A couple of questions, just information that would be helpful as we go forward. The first is that I think I'm correct in recalling that diabetes is often comorbid with other conditions. And so understanding that would be helpful. Secondly, and I think this is for our plan friends, knowing which tiers these things are on now. I mean, are some of them on tier 4 because of the cost is now so high? Are some of them, are mostly they on tier 2? Are some insulins on tier 3 and some on tier 4? All that kind of stuff, finicky as it is, I think will help to inform our thinking. And I don't, I'm not an expert on insulin. I happen to know that the kind of high blood pressure medicine I take is one of 10 or 20 generics in the class. And so, you know, I know sometimes there are lots of things in a class and sometimes there are only a few. And so understanding that as well as we move forward, and just echoing again the comments of of Jen and Carrie about the, you know, we're not controlling the underlying costs here, and we're also dealing with one condition, and because the AV the tyranny, we call it the tyranny of the AV calculator, the impact on other conditions makes us worry. So after all these years of dealing with benefit design, that's what we call it. Thanks.
Thank you, Beth. James, there are no other hands raised or questions typed in at this time.
All right, thanks. Let's go to the next page. We can kind of wrap this up here. As mentioned, we will be working on this in more detail in the benefit design work group. We still need to run some of these queries to generate some of the information that you spoke of. Now, some of these we already had in process. Others are good comments. Level of comorbidities is something I think that we should be able to generate relatively easily. So to the extent that we haven't been able or didn't have it on our planning horizon, if you have information that you would like to see, there's a good chance, following AB 99, that we have the data to be able to answer that for you, including cost-related metrics. So certainly let us know if there's specific information you would like. I've taken notes on everything that's been brought up today, but if there are other things you think of over the coming days or weeks, please let us know. And there's a good chance we will actually be able to find out that information for you. We don't have a time frame scheduled yet for these the subcommittee. We want to finish collecting some of this information before we do. Also give you a chance to provide your feedback on this topic if there's anything that comes up over the next week or two as you discuss this with colleagues or have some more time to think about it. So I can't commit to necessarily this subcommittee starting in September versus October or whatever, but they will start relatively soon. And of course, we'll be talking about some of the other potential benefit design changes for 2023 as well. But I know that this topic is a bit different from what we normally handle, and so I wanted to make sure we weren't missing anything as we went into the exploration of it. So again, if you have any comments you want to provide or questions or whatever, Wandy Ma is going to be heading up much of this effort here at Covered California, so send your comments or questions to her, and we'll collate them and get back to you or incorporate them in our analytics as necessary. And with that, I think we can move on to the update on our contract refresh. All right, so we are issuing our proposed, I would say, a draft of our proposed 2023 to 2025 health plan contracts very soon. I think we may have already posted the standard template contract, and we were going to try and get attachment 7 out by the end of this week, which is really by tomorrow. One thing I want to make everyone aware of is that as a new contract, we are actually going to renumber attachments so that we don't have blank spaces. And what was traditionally been known as attachment 7 will no longer be attachment 7. Maybe we should have some contest to see what we should rename it to. It's going to lose its branding. Everyone knows it as attachment 7, but that's just not going to work anymore. Attachment 14, so attachment 7 is our really quality improvement delivery system reform section. Very important. It's something that people are really interested in. Attachment 14 is more the performance standards and guarantees of particular interest to the health plans, although other people are interested as well, I'm sure. Again, just like attachment 7, it will have a new attachment number under the new contract. We are looking at some potential revisions beyond what we've considered before, so that's not quite ready. We're hoping to get that out in the next few weeks, but we don't have a specific time date yet. So get started with the rest of the contract, get started with attachment 7, and hopefully it won't be too much trouble for you to go through attachment 14 on maybe a shorter time frame once it's available. Now, most of the changes for the standard part of the contract, not attachment 7, not attachment 14, the standard template of the contract, changes aren't what many of us would consider significant. If you're not a health plan, you may not be interested in those changes at all, but we wanted to make that available so that you can see what they are. We've summarized what those changes are in the appendix to this presentation. I'm not going to go over them. They're kind of nitpicky. And of course, if you have any questions or feedback, you can get back to us later. You don't have to do that today if you don't have the time or haven't had a chance to review them yet. And with that, I think we're ready to move on to the next slide, which I believe is Margaretta's section.
Hi, James, and hi, everyone. This is Margaretta. So we'll just be walking through an update of where we are with attachment 7 and attachment 14 and the quality transformation initiatives, just to provide a little more context and expand on James's updates here. So if we can move to the next slide. So this is just a reminder of our workings for the Health Equity and Quality Transformation Division related to the overall contract refresh. So we're working on, attachment 7 refresh. We're working on developing the measure methodology and benchmarks for quality transformation initiative, and then we're working on developing key performance guarantee for key areas within attachment 7. For attachment 14. And then additionally, we'll be developing a quality playbook that transitions some of the requirements from attachment 7 into more of a best practices document. So today I'll be focusing on updates for attachment 7 and the quality information initiative, and then provide a little bit of update on the quality playbook and attachment 14, which are coming soon. So if we can go to the next slide. So as many of you know, we did a quite large amendment in 2022 for attachments, and building off that amendment, we are aiming to kind of keep most of that groundwork that was laid in 2022, but we are reorganizing attachment 7 to try to make it flow a little easier, be a little kind of more organized and simplified in terms of the article structure. So a big change is that in the 2023-2025 attachment 7, we will have essentially 6 articles. So it's a big change from our previous, I think it was 17 articles in 2022. So we essentially kind of Article 1 focuses on health equity and disparities reduction. Article 2 focuses on behavioral health. Article 3 focuses on population health, so kind of combines a few previous articles. So population health, health promotion and prevention, social health, and at-risk enrollee transition efforts. And then Article 4 is where we've combined a lot of our delivery system strategies. So effective primary care, integrated delivery system, ACOs, network based on value, telehealth, and then quality collaboratives. And then Article 5 is our focus on measurement and data sharing. So combining our measurement articles of requirements around QS and NCQA reporting, and also our data sharing requirement around HEIs and HEI data submission to Cover California. And Article 6 wrapped up with our certification and accreditation requirements. So in addition to our release of attachment 7 tomorrow, you will also get a supplemental document that provides both a summary of changes, of kind of highlighting the changes that we made in the article, and then also provides a crosswalk of what was the article in 2022 and where have we kind of transitioned the content to in 2023. So we hope that those are helpful documents to support your review of attachment during our public comment period. So if we can move to the next slide. And this is just a reminder of kind of our overall timeline, is that we are aiming to release the draft of attachment 7 for 2023-2025 tomorrow. And then we will have about a 4-week public comment period, and we'll provide the specific dates via an email that you will all receive. And then, once you get those comments back, the team will work to update the draft and also respond to comments, and then we'll bring the revised draft to the board for discussion in November. And then we'll have another round of public comment and edit the draft based on comments and any board feedback, and then provide a final draft to the board for approval in January of 2022. If we can move to the next slide. So this just kind of summarizes and outlines a lot of the information that I just went through. I need to release the draft tomorrow, and we'll provide a supplemental document that includes a summary of changes and a crosswalk. We will sending out the draft to all issuers, all Attachment 7 Refresh workgroup participants, this group, and any others like regulatory liaisons via email. We'll have probably about a 4-week public comment period, and we'll provide a specific due date via email. We'll also provide a template for you to provide your feedback in an Excel spreadsheet template. And also just a reminder that all documents will, of course, be posted on our HVAC's plan management page. And we have, I think just this morning, kind of redesigned that page so it's a more clear what is the 2023 content for the refresh and what is the previous 2022 amendment content. And of course, if you have any questions or comments, you're welcome to submit them to Ty, and he kind of helping track our overall Attachment 7 Refresh stakeholder engagement process. And I think the last reminder I wanted to make about Attachment 7 is that we provided a broad overview of each of our priority areas in the Attachment 7 Refresh work group last week. So that presentation and I believe also the recording are available on the HVAC management page. So if you want to go back and kind of review the major changes that we're looking to make, that is available on that HVAC page. So I think I'll pause here before I go on to QTI, but just have another quick update on QTI.
Thank you, Margareta. We do have a question here. Can you include the text red line in addition to the crosswalk?
No, we will not be providing a red line for 2023 Attachment 7 because of the major changes with the reorganization from 17 to 6 articles. The red line would have been quite extensive. And additionally, this is a new contract term, so we are, we're aiming to kind of start fresh with a new contract for 2023. So we'll not be providing a red line. We will be providing subsequent red lines after, public comment and with each round of public comment.
Thank you. And will you be releasing Attachment 14 around the same time as Attachment 7, or is that a different timeline?
It's on a different timeline. James mentioned we're still working through the development of Attachment 14 and to release it sometime later this month.
Thank you. And we have a hand raised. Beth?
Yeah, so Margareta, remind me, we've been working on this contract now. I mean, it's literally a decade old, right? So it's probably time. And I don't think either you or James were involved in drafting the original one, but I was around, and all I can say is I was grateful. I wasn't expecting to sign it. So it's not a surprise to us. I think my first impulse is to want a red line too, but at some point a real refresh seems in order given how long it's been and what a scramble it was to get that first contract done. I just want to reflect that and appreciate that you've been as always, the Covered California staff has really tried to bring us all along on this journey that we've been on and to give us all time to provide input and think about it. And I'll still probably be irritated when I have to read the whole darn thing instead of just the changes. But I appreciate why it is that red line doesn't make sense. Thank you.
There are no other questions or hand raised.
Okay, then we will move on to the Quality Transformation Initiative update. So following up again on our refresh work group last week, we provided kind of a more comprehensive overview than we provided in the past of our proposal for the design and the methodology and candidate measures for the Quality Transformation Initiative. So we will be releasing essentially kind of a formalized slide deck with the QTI design and candidate measures for feedback. So it will include all the details from the presentation last week, along with specific requests for feedback from this group and from others. So again, we will be sending that PDF of a slide deck out to issuers and this group and the REACH work group participants and regulatory liaisons. And then again, we'll have about a 3 to 4 week public comment period. We'll provide the due dates via email. We will also provide a comment template Excel spreadsheet with the slide deck. And again, as soon as it's available, all of these documents will be posted on the ABEX Plan Management page. And you're welcome to any questions, comments in the meantime to me about the Quality Transformation Initiative. We're really essentially hoping for this groups and the broader group feedback on the design components, how we've kind of designed the QTI and the penalty structure, and then the measures themselves, and number of measures and which measures should be included in the measure set. And so we are hoping that this gets us started on the feedback process for the Quality Transformation Initiative, and then as we move forward in the process, we'll be releasing more kind of formal documents that provide more context for the Quality Transformation Initiative. And I think that's it for the QTI, and would welcome any questions or comments.
There are no hands raised or questions typed in, Margaret.
Okay. Well, thanks everyone, and yeah, look for your emails tomorrow with the draft of the 2023 attachment amendment and the Quality Transformation Initiative presentation.
Great, thanks, Margareta. I'm sorry, James, was there?
Yeah, let me just jump in really quick. I do want to reiterate something that Margareta mentioned about our timeline for the contract, and that is we don't plan on putting a version of the contract to the board until November. What this is, this September release, is the opportunity for all of our stakeholders to provide feedback so that we can get a copy to the board that incorporates all the concerns and issues that get raised by stakeholders. So, again, this isn't your only bite of the apple, but we're trying to get as complete as possible a contract to our board in November, and by you reviewing the documents over the course of the next month or so and getting us feedback, that will enable us to do that. And then hopefully we don't have to make a lot of changes before the board makes its final approval in January. But I do want to call out that we'd really appreciate you to provide feedback over the course of the next month, but it's not going to be your only bite at the apple. We'd appreciate early movement if you can. And with that, I want to turn it back over to Rob.
Great. Any open or walk-on items from the committee members or board members or members of the public that we wanted to discuss?
We do have a question here. Is the certification application being revised for the 2023-2025 contract period as well? If so, any idea when the draft will be available?
Yes, it is. Typically, we have a draft available in December, I believe. We're going to try and maintain the same schedule we've had in prior years. One of the changes we have is that in the past, we have had a reduced or maybe there aren't as many questions that have to be answered for returning carriers. As a new effort where we are opening up to all carriers, we're going to expect all carriers to apply as if they were a new carrier, so that's additional work on their part. But we are trying to restructure the certification application as well. And hopefully we can move some of the things that were in the certification after the first year. They can be handled as part of the contract and don't need to be submitted as part of the certification process, which should reduce some of the burden on our carriers. Some things, just we think probably don't belong in the certification and maybe just live as part of the contract. So we're doing a look at what we can do to pare down what has to be submitted in future years, understanding that as a significant change where we expect to have a lot of applicants, all the carriers are going to be expected to fill in as if they were a new applicant for 2023. So they won't see the benefit of this probably for another year.
Thank you, James. And a comment in addition to that is, since 2023 is a rebid year, we would appreciate as much time to review the certification application changes as possible. Thank you.
Okay, doesn't seem that there are any other questions or comments. Just a reminder that next Thursday, the 16th, is the Covered California Board meeting. Open session is estimated to start around 1 p.m. I don't know if we'll be having a plan management advisory meeting in October. I think the board meeting is tentative as well, so be on the lookout for information from Ty or James about October's plans. And with that, I will draw this meeting to a close with a thank you for everyone for your participation today.
Thanks, everyone.